to our 19th session. Today we have a topic on culturalized, marginalized community. We can have the presentation of ma'am for around 40-45 minutes, followed by a discussion. So the presentation will be taken by SMRITI Rana. She's not a unfamiliar face for us. Welcome, ma'am, to the session.
Thank you. Thanks, Raju. And nice to see a lot of familiar faces. Just a disclaimer before we start. Today's session on culturally marginalized communities, rather than a session provide palliative care to these communities, it is more a sensitization. So I will request you to view it with that lens. It's just about getting to know who these communities, some of these communities are, and why we consider them marginalized. And this is, I would recommend that you consider it as food for thought in your own practice and how it can be adapted to the work that you all do in your own places. Some of you might be familiar with some of the communities that we talk about today, but for me, this is still an area of much learning. And so if anybody has anything to add, I'll be happy to stop after each section and take questions or comments. Yeah, so I'm going to share. Also, one more thing is we did have a case presentation that was created by one of our social workers, Teresa, but because of certain time constraints today, we're not going to be presenting the case, but we will be sharing it with all of you because it gives a very comprehensive idea of what migrant workers go through in the state of Kerala. But of course, that is something that will come to you later as a learning material. Right, Raju?
Yes, ma'am.
All right. So, so I'm just going to share the presentation now. Is that clear? Is it on screen?
Yes, ma'am.
All right. So first off, we need to understand what the word marginalization really means. And we've all heard the phrase, we've all heard the word, but to really understand why someone is marginalized or what marginalization means, I think that's a good place to start. So to marginalize somebody is to, push them aside or relegate and assign them to an unimportant or powerless position within a society or a group. And this is something that happens quite often. There are several communities that are marginalized. And the last session, we talked about the LGBTQI community and they're socially marginalized. Today, we're going to talk about people who are culturally marginalized. And there are different kinds of marginalization that take place. There is marginalization that's done medically. There is social marginalization. There's cultural marginalization. And so today we're going to just deal with some groups that are culturally marginalized. And marginalized groups are people who, for whatever reason, there are several reasons, they are denied involvement in mainstream economic, political, cultural, and social activities. And if we look around, all of us can quite easily identify marginalized groups that we come in contact with on a daily basis. So today, I am only going to talk about these three groups: migrant workers, tribal populations, and sex workers. There are many more marginalized communities, but it would be unfair to try and cover all the communities at one go. We are starting with these three because I think these three are some of the most commonly marginalized groups that we come across. So to start with, I'm going to start with migrant workers. There's been an increase in urbanization in India from 2001 to 2011, and this is as per the census, from 27.81% to 31.16% in 2011. And all the data that we're going to discuss today is going to be connected to the 2011 census. Now, why has there been such an increase in urbanization? There are two reasons. One is, of course, our population explosion and poverty-induced rural-urban migration. So people are moving more from rural areas into urban areas looking for jobs. And as a result of this increase, today we are seeing that in India we have 139 million internal, that is including within the state and between states, migrants in India. So this is as per the 2011 census. Sorry. Yes, can you hear me?
We didn't hear you in between.
Okay, so what I was saying is, as a result of this massive movement of people, we now have 139 million internal migrants in our country, and that is a staggering number. That's a huge number. Also, I want to point out that it's in the last few years that the idea of smart cities has come up. The government decided that 100 smart cities would be created in India, and the idea of a smart city is not so smart for migrant workers because it takes migrant labor to build these cities. But ironically, these migrant workers are left out of the healthcare system and also economic systems and things like that. Okay. If you look at what the trend is, the major source states of migrant labor, the top of the list are Uttar Pradesh and Bihar, and followed by Madhya Pradesh, Punjab, Rajasthan, Uttarakhand, Jammu and Kashmir, and West Bengal. And where are all these people going? Primarily to Delhi, Maharashtra, Tamil Nadu, Gujarat, Andhra Pradesh, and Kerala. So if you were to put this on a map, you can see that there's a lot of north to south and east to west that is happening. And that gives you the trend of the migration patterns. Some of the challenges we face in trying to pin down the migrant population is that there are no accurate figures. And official agencies tend to underestimate short-term movements. Now, there are long-term migrant movements, like people who go and settle down in urban areas, but there are people who will only go for particular seasons when the work is available to them. And the seasonal migrant workers are even further left out in any sort of counting of figures. And the other challenge is that the census data that is collected is usually done after 10 years. So what we're actually looking at is stock data. We're not looking at real-time movement. We're looking at movement that has been recorded, and there's a 10-year gap between each bit of data that is released. So these are challenges. So we're not working with real-time figures, but even without that, 139 million is a huge number, right? Now, what are the sectors that people usually engage migrant labor? Are construction, hotels, textiles, manufacturing, transportation services, and domestic work. Now, I'm sure my colleagues in Kerala are quite familiar with, you walk out and you see migrant labor everywhere. In fact, we're in a facility right now in Vattapara where there's construction work going on, and we had the opportunity to have a conversation with 12 migrant workers who are there, and most of them are from West Bengal and Orissa and Bihar. So in preparing for this talk, we had a chat with them, and a lot of what we learned from them has also been incorporated into this. A lot of migrant labor across the country are in very low-paying, hazardous, and informal market jobs. Okay, so there's no real safety net for them. They're recruited and they're brought. And this is what typically healthcare then looks like for a migrant labor. Someone coming from West Bengal or Orissa to Kerala is going to have several barriers, including language. Not knowing that certain healthcare options are available. Not having access to subsidies that are available to residents of Kerala. I mean, I'm just going to take the Kerala example here, but I'm sure you can apply it in your own settings as well. And because they have poor access to healthcare services, they have poor occupational health. And then they cannot access hospitals in these places for several reasons. Either they don't have the right ID proof, or they don't have, a lot of hospitals require family members to come in as attendants, things like that. So they don't have all of that, so they cannot access hospitals. And because they cannot access hospitals, they usually go back to their villages. And once they go back to their villages, they lose their jobs. And as a result, they lose wages. They're further impoverished. And then they have and further pushed into a space where they have poor access to healthcare services. So this becomes a very convoluted and terrible cycle that they get caught in. And typically, if you look at it, this is what a migrant worker's life really looks like. Most migrant workers get into migrant labor work very early in life. So around 14 to 20 years of age, they enter the migrant labor force. And they are then the secondary wage earners. They may not be the primary breadwinner in their family, they're secondary wage earners. And then their work life peaks when they're about 21 to 27 to 30 years old. At this point, they're doing hard manual labor for up to 12 to 14 hours a day. And I'm sure all of us in Pallium India, this is the group that we're actually seeing just outside of our hospital, right? And these guys are now the primary wage earners. They become the breadwinner of the family. They send money home, and they probably go home once a year, or for 1 month in the year or so on. And this is also the time when they do go back home. They're of a marriageable age. They're quickly married off, and they get to start a family, and then they come back. So this is typically what happens in this part of their life cycle. By the age of 27 or 30, or going up to 40, it's the beginning of the exit. This is where they have to start thinking about going back to their homes. And also, because of them putting in 12 to 14 hours of manual labor every day, they start developing health problems, and it starts to take a toll. And they might, because they can't access healthcare systems in the cities, they have frequent returns to their village with chronic illness, and eventually they lose so much of their wages that they have to go back and find something to do back at home. And finally, by the age of 40, people have started going back to their villages, at which point they go back, they try and find local labor opportunities where they come from. This reduces their earning capacity quite a bit. And then what happens is, by then they have children who then enter the workforce. And so the cycle becomes a pattern within families. So it's not that one migrant laborer, he's the only one in the family. It's quite likely that his son will also become a migrant laborer. So this is another vicious cycle that migrant labor workers face. While they are engaged in migrant labor work, they have all kinds of challenges. A lot of them don't get paid their wages on time or at all. There is physical abuse. There's a lot of evidence that they're not treated well, and there is physical abuse. Accidents and even death, because they're working in construction, they're working in high hazard jobs and so on. Accidents happen. They're not covered. There's no safety standard. There's no safety net, and it results in death quite often. Most of us are not we don't know, we have no clue what kind of legal disputes happen in the unorganized sector, what violations take place in the unorganized sector. If I were to ask all of you today, how aware are you of this? I have a pretty good idea that most of us in this discussion itself would not know what these legal issues might be. These are people who are not part of the voting bank. Because they're moving around so much, they're not at home to cast their vote. So they are ignored by politicians. Politicians don't value them. So policies don't get made to safeguard them at all. And due to constant movement, they're not protected by trade unions either. They don't stay long enough in a place to join a trade union, which will then fight for their rights or protect them or make sure that their well-being is looked after. Very often, they have very unhygienic accommodation, and a whole bunch of them might be asked to share a very small space. That is, if at all they are provided that space. A lot of them are left to fend for themselves and end up living in very slum-like conditions. And usually a lot of the migrant labor are from historically marginalized groups like scheduled castes and tribes, which adds an additional layer of vulnerability to them. So these are some massive challenges. And I mean, to put it in perspective, I would ask you to look at it if we in our work had to face any of these challenges. It's, when we think about other people going through it, we can look at it quite intellectually and academically. But if any of these conditions were imposed on us, I'd like you to take a moment to think about what that might be like. And also, let's remember that they're doing all of this without any family support close to them. They don't see their families often. And very often, if they have a child, they see their child a year after the child is born and so on. What is really needed for them is registration, photo IDs that are helpful in emergencies, employer verification, and at banks. Now, when the demonetization, for example, when demonetization took place, I'd like you to think of the impact it would have had on these people who get paid in cash, who have no bank accounts, who would not have been able to, overcome that tide. What would they have done? How would they have gone back home? And recently, one of the migrant labor workers that we spoke with told us that he had an insurance card, but somewhere on his train journey back to West Bengal, he dropped it and he couldn't find it. And his contractor was not going to get him another one. So what actually happened? Then the card becomes completely useless, right? Legal education for not just them, but for us as well. We need to understand what their counseling needs are, what their legal needs are, and mediation through lawyers and paralegal workers. Now, this is something that we do for the patients that we look after in our home care, in our community outreach work and stuff. We do engage legal aid when they need it. And that goes a long way in their overall well-being. So that is why this is important. Primary health clinics should be made available, should have a service where health camps should be organized for migrant laborers. At the moment, a lot of them have no clue where they can go for healthcare if they fall sick. And medical consultations, medication and referrals should be made available to them. Now, they are in no position to actually come out and ask for these things because they're working 12 to 15 hours a day. So as healthcare providers, we need to make this available to them. This is also palliative care because we are preventing suffering. Palliative care, by definition, is the prevention and relief of suffering, right? So just because they are not domicile residents of our state does not mean that they should not have access to healthcare. And that onus really comes to people like us who are in the business of providing that kind of health service. And what would really go a long way is to provide creches for children of migrant workers. We see an increasing number of women getting into migrant labor work. And when they have children, they have no choice. They have to carry their children with them to construction sites or to their work. And that very often complicates things for them. And the child's health is also at risk. So probably creches for children of migrant workers would also be a really good idea if that's something that can be provided to prevent suffering of the child as well. Okay. Now, before moving on to tribal populations, is there any comment that anybody would like to make? How this all ties up to palliative care, I will bring back at the end of this presentation. So apart from that, if there are any other comments or questions, I'm happy to take them.
You can raise your hands or unmute yourself and speak. Nidhi?
Yes, ma'am. I would like to ask about legal education you mentioned in the last slide. Like how we can provide the legal education and what are the resources like legal education and counseling that you mentioned.
So thank you for that question. I'll give you the context in which we provide legal aid in our setting. So sometimes when we come across, say, elderly people living alone, or a woman who is a victim of domestic abuse, or so on, we have a lawyer that we have sort of engaged on a I wouldn't say on a retainer basis, but we have a relationship with her where we say that, in certain cases where we need legal advice, can we come to you? And she's actually been associated with Pallium India for a very long time now, for many, many years. And so what needs to really happen here, Nidhi, is for us to sensitize the legal community. So what we do is we have law interns coming to work with us. In fact, we have a few of them coming next month. And it's interesting how palliative care and legal aid can come together. So when we have interns coming, we ask them to look into particular laws that affect or are applicable to certain populations, especially that we deal with. So vulnerable populations. It could be elderly people, it could be women, it could be children, it could be people with disabilities, so that we have a ready reckoner of knowing what the rights are. Now, this is a two-way street, in my opinion. It means legal education for us as institutions and healthcare providers, as well as having a docket of things ready where we know where we can intervene and where we probably cannot. So I would encourage going out there into your, into the circles that you have in your city, identifying a legal expert. It could be just one individual. It doesn't have to be a law firm because we can't afford that. But just engaging one person who probably has expertise in law, but has would like to contribute to the field of palliative care or healthcare, and this is something that can be done. So there's no hard and fast formula, but it is about forming an alliance with people outside of immediate palliative care circles. So if you have any access to any lawyers, I would ask you to start a conversation with them, because if you are seeing a certain group of people who require some sort of legal aid, then that's a good place to start. And definitely get involved with interns and like students who are looking to, who have an interest in laws pertaining to healthcare and so on. So did I answer your question to a certain extent? Sorry, you're muted.
Yes, ma'am. Yes.
All right.
Thank you, Divya. So, ma'am, I think you can continue with the presentation. We can take questions at the end.
All right, sure. Okay, tribal populations. I live in a very interesting place where, I'm just at the crossroads of Kerala and Tamil Nadu. That's where I've grown up, and there's about 7 tribes that live here. So we've had some close encounters with them. And recently, I was in Arunachal, where again I had the privilege of meeting several people from different tribes. And I won't call myself an expert by a long shot, but some of the learnings that we have come across are what I'm going to present. Just on the outset, there are 104 million tribal people as per the 2011 census. Again, a very, very large group of people, 104 million. These are spread across 705 tribes, and they make up a huge population of tribal communities. Percentage-wise, Lakshadweep has the highest, but also we have to remember Lakshadweep is quite tiny. 94.8% of its population are tribal. Nagaland is a close follower with 86.5%. And other states include, of course, Madhya Pradesh, Chhattisgarh, Gujarat, Rajasthan, Andhra Pradesh, West Bengal, Karnataka. This is not to say that other states don't have tribal populations. These are the ones with significant tribal populations. And in terms of the size of a tribal community or a particular tribe, the Bhil is the biggest, and they're most widely distributed across India, from Rajasthan, Gujarat, right across. And they're the largest tribe in South Asia. And then, of course, you have the Gonds that are in the east of India, central and east India. So this is just a sort of snapshot of what the population breakup is. Tribal populations rank very, very low on various economic and educational indicators, and also access to social amenities. And when we're looking at them through the lens of healthcare, there's a threefold disease burden. One is malnutrition is a big problem, and communicable diseases are also rampant, and that has historically been the case with tribal populations. But now we're seeing a trend of an increase in non-communicable diseases. And these non-communicable diseases, from cancer to various other conditions, are attributed to changes in lifestyle, environmental stressors, and rapid urbanization. So there's a huge amount of displacement that is taking place in the name of development. Of course, there are various laws and things happening at the same time. But the stress on a tribal community when they are forced into lifestyle changes for the sake of development, or whatever you want to call it, it is huge. And of course, now they're seeing there are more recorded cases of non-communicable diseases amongst tribal communities than ever before. And it comes from an exposure to mainstream communities and dominant communities. And the third, which is a very, very poignant issue, is mental health and addiction. It is becoming a huge problem amongst most tribal communities across the country and across the world. I will not restrict this only to India. Mental illness and addiction is something that we're seeing in tribal populations, indigenous populations across the globe. And I mean, one of the things that and I'm sure my colleagues from the northeast of India will validate this, that, when I went to Arunachal, I found that in like Dibang district alone, 80% of the population there, which is primarily tribal, was addicted to opium. And the thing is, they are so socially marginalized. There's lack of infrastructure. So it goes into a loop where, they don't have access to de-addiction. They don't have access. They barely have, they've barely got services that help with detox, but that doesn't really help. And suicide rates are on the rise across tribal communities in India. And there is an interlink there as well. So we're seeing huge surges of instances of depression. We're seeing huge instances of substance abuse and like I said, suicide. And this is all related to the fact that a lot of these people are being forced to to give up their homes, move out. They're being put under pressure for various things, and it is a big problem that is impending. Now, again, like when we talked about migrant workers, there are some challenges just in terms of the data we can work with. And one is that there is a lack of data. There are lots of estimates and stuff, but in terms of accurate data, that is lacking. Monitoring and evaluation is is weak at best. And this is also attributed to the fact that a lot of these communities are difficult to access simply because of their geographical locations. And there is a lack of professional will to serve in these communities. Most healthcare professionals do not want a posting in some, back of beyond tribal community. Some people might have a passion for it, but by and large, somebody who's entering the healthcare field is not going to like being posted somewhere for 2 years where they don't have access to their, to the amenities that they might be used to. And there is an exclusion of tribals from planning, priority setting, and execution. There are policies being devised for tribals all over the place. But how many tribal people really are present in those policy-making decisions? How much say do they have? Is it a shared decision-making process? By and large, it isn't. So the decisions that are being made for them don't include them when it comes to setting the goals. And there is a serious lack of transparent accounting of actual spend on tribal health. It's very, very difficult to keep track of it. We already have a burden of corruption and stuff in our country, but when it comes to speaking up or allocating funds, actually effectively using them, reporting back, that is a serious issue when it comes to dealing with tribal communities. Now, there is the issue of intercultural communication. Now, from our point of view, what I would like to sensitize all of us is to the fact that there are many differences. There is a difference in worldview that tribal populations have, and that is different from how we view the world. There is a huge degree of fatalism, and there's a huge degree of, this is how life is, this is how it's meant to unfold. And a lot of tribal populations still have a deeply shamanistic worldview, and they have their own healers, they have their own systems of faith, they have their own systems of healing. And it's very, very interesting that no matter how much medical help you make available, there is a tendency to fall back on what they have believed in for generation upon generation, right? So their worldview itself is quite different. Ways of processing information is different. What is important, vital information to us to survive in this world is not vital information to them. How they navigate the world is very different from how somebody who is educated in mainstream setting would navigate the world, right? What is important in terms of how you must live your life? What is important information in survival? Now, people like us living in the city, what we consider as vital information, a lot of it is what we need to know in order to survive and navigate an urban setting. There's a competitiveness, there's all kinds of things that we need to be aware of. There's a street smartness that we need to have. But ways of processing information is very, very different in tribal communities. The perception of death is very different. And I spoke with several experts who work very, very closely with tribal communities. And there's one incredible organization called Accord, which is in Goodlaw here, very close to where I live. And they've been working with the tribal community for like decades. And one of the things that the founder and the doctor there, she told me, she said, is there's a tendency to look at, if they're sick and they feel that death is coming, it's almost like lying down and dying. But it's not in a sense of giving up. It's just equanimity. There's a sense of equanimity that now my time is up. I am mortal and it's time for me to go. And several experts have sort of revalidated the same thing. I'd like to tell you a small incident where the tribal head of the village nearby, I was called in because he had end-stage lung cancer and he was in a lot of pain. So we went and we got some morphine and all of that organized for him and stuff. And so I visited the family several times, and because we all lived in the same area and community, we all were well known to each other. And then I get a call one evening saying that, he's not doing very well, so can you come across? And I'm not a medical doctor, so I wasn't sure what I was being called for, but I went, and I was quite amazed to see that, he clearly was in the stage of active dying. His breathing pattern had changed, and I had seen him just that morning, but just in those few hours, a lot had changed in terms of his physical condition. And because being a palliative care person, I recognized what we call the death rattle. And I was really wondering what I was supposed to do in that sense. But then suddenly the oldest woman in the village was called in, and she came in. She insisted that nobody cries. Anyone who cried, she threw them out. And then they got a bowl of like this porridge. And then she called every immediate member of the family into the room, made them take a spoon of this ragi, of this porridge, and put a spoonful in his mouth, which I thought was quite shocking because he couldn't swallow. But it was done in rapid succession, after which this old lady sat with him, and he passed away. Now, how that death process took place, I'm not going to comment on. I think a lot of people would be shocked that this ritual was conducted, but it was actually to see him off, and every single member of his family was invited to participate in that ritual. You could say that it was a kind of euthanasia also that took place, but that seemed to be part and parcel of how this community did it. And once his breathing had completely stopped, this old lady, she invited the rest of them in, and she said, "Now you can cry." And then there was a lot of chest beating, and but it was an actual expression of grief. To me, this happened many years ago, and to me, it felt like a very, very, at first, a very unnerving experience. And then later on, I was told that I was invited there because I helped the family through a certain part of their lives. It was important that I bore witness to it. So tribal communities will also include you in the story. Okay, and it's their way of I suppose honoring your presence also, which is again, it's an issue of communication. It's about us looking at it through that lens as well. Ways of processing grief and their rituals of mourning and expression of grief are also very different, right? We expect that grief is expressed in a particular way, but that's not always the case. From what I understand, there are certain rituals that different communities follow. Some of them are more muted, some of them are more sort of, chest beating and really letting the world know that they're sad and sorry about what happened. But there are vast differences in how grief is processed as well as expressed. We have to be very, very aware and mindful that body language is very different. Okay, we might say, yeah, we're all Indian, whether we're tribal or not, but we have to be acutely aware of the fact that body language plays a very, very big part. Eye contact, I've just put one example there. We are taught that, making eye contact is a sign of trust and it's a sign of being straightforward, but with a lot of tribal communities, that's not the case. Looking away is a sign of respect. Now, what does that do? Now, if a doctor in a tribal community has a tribal person coming to them and this person is looking away and not really making eye contact, the doctor might think that he's lying about his symptoms, or he's not giving him the whole picture. Because, if somebody's looking away from us when they're talking, you don't tend to trust them very much. But this is how they also express respect. I heard this beautiful story about how in certain tribal communities, they don't stand face to face and look eye to eye. They stand next to each other, looking in the same direction. And they believe that it's a heart-to-heart communication versus an eye-to-eye communication. So if someone from a tribal community comes in, has a conversation with you and stands beside you rather than in front of you, then we need to understand that possibly that is their way of communicating with us. Verbal language, of course. So I'm going to just sort of separate this into dominant cultures and, tribal cultures, dominant cultures being us. And, very often we are encouraged to ask direct questions and we expect an immediate response. If a doctor asks a patient a question, they expect the patient to respond immediately. But in a lot of tribal communities, it is believed that there is a space that is required because they want to answer the question in full. Now, if you ask a tribal person, "How are you?" he's going to actually think about it and say, "Okay, how am I? How is this question to be answered?" and so on. So that the very rhetoric of the language is very, very different. but that requires patience on the health provider's side, right? You can't get impatient with this person because he's not answering you quick enough. And what happens then is it tends to lead to, rather than asking a person from a tribal community an open-ended question, which may lead to a lot of prolonged silences and thinking, doctors will then tend to, or healthcare providers will then tend to ask very direct, close-ended questions. Do you have a fever? Do you have a cough? So that also sort of shunts the entire process quite a bit, and there is a breakdown of communication that happens. So these are things that we have to be very, very careful of. An interesting perspective that was presented to me over the last few days as I spoke with people who worked closely with tribal populations was that it appears that their threshold for pain is higher than what we have. The rest of, the non-tribal communities have. Now, there's a lot of speculation about this, whether or not it's true, but it tends, I think the capacity to bear pain seems to be higher amongst these communities. Now, I'm not going to, conclusively agree or disagree with that. I think again, it goes back to how information is processed, what is accepted as fate, what is accepted as mortality, and there could be several factors at play there. But this is something that I've heard from several experts, and I think it's a really fascinating idea, especially for people who, like us, who work in the field of palliative care. A word of caution, of course, is we need to recognize that each tribal community has a deep sense of dignity. And there is a tendency amongst us so-called mainstream educated people to believe that we know what is best for them. And we end up going there and telling them what is best for them. Or we try and set up healthcare systems that suit us and we think will suit them. And this kind of paternalism, this looking down upon, or dismissing their perspective and replacing their ideology with ours, or laughing or mocking at the fact that they believe in tribal remedies and things like that, there's a deep risk we run. And this is something that we tend to do quite frequently, even sometimes without realizing that we're doing it. We tend to think we know what's good for them. So word of caution there. If you find that you're going to be working with tribal communities, I think the best advice that I was given was to really go and observe. And if there's something that you're unfamiliar with, just observe what they do within the community, what is seen as respect, what is not seen as respect, what is seen as healing, what is not seen as healing, and then sort of work within that framework. Okay, and coming to the final group today, sex workers. When we talk about sex workers, I think there's an immediate, response that we all have. I mean, I'm not saying it's negative or positive, but the term sex worker does conjure a response. We have a stronger response to the phrase sex worker than we might have to a healthcare provider or to a accounting executive or to a migrant worker, right? So historically, sex workers have had a bad rap in terms of the work that they do or why they do it, and very often people think that they're doing it out of choice, and they've chosen the easy way out. Why can't they go get themselves a decent job? So there are lots of these ideas that immediately sort of through our socialization come to the forefront when the phrase sex worker is presented to us. But I'm going to come at this only from the point of view of the difficulties that the community faces. And in telling you about the barriers they face in accessing care, I hope to illustrate through that some of the issues that they face on a day-to-day basis, what we take for granted, right? And I hope that through talking about the barriers they have in accessing care, I can sort of paint a picture of some of the difficulties that they experience. First of all, there is very low education and awareness in this community about what care is available to them. We are it's very easy for us to go into a community and talk to them about say maternal health or child health and so on. But how many of us would be really comfortable walking into a community of sex workers and understanding what their needs are and what is available to them? I'm not sure I'm aware of what care services are available specifically to sex workers right now at this very moment. I know of organizations that do some fantastic work, but off the top of my head, if I was asked what is available to them, what are their rights in terms of healthcare, I wouldn't really be able to tell you. And that is something that I hope to educate myself on sooner than later. There is an obvious stigma. Because somebody is a sex worker, care might just outright be denied to them. And very often, if the patient is a sex worker, they may not feel safe going into an institution, right? Or they may not feel safe accessing healthcare. And of course, they will not be respected. I mean, let's face it, there's a deep discrimination in our society against sex workers. And if anybody finds out that someone is a sex worker, immediately there's a guilt associated with it. I mean, if we just see the amount of guilt we apply on someone who has cancer, like immediately when somebody who's been diagnosed with cancer is asked, how many did you ever smoke? Did you ever drink? So it's almost trying to find a reason why they have the condition they have today. So if somebody is a sex worker, the stigma and the prejudice against them is already stacked high. The conditions within which sex workers live, very often, again, very unorganized. I mean, some of it is highly organized, but a lot of them are not living in conditions that allow for, what we would be able to produce as identification or as supporting documents in order to access certain amenities and utilities. Utility bills, tenancy agreements, identity proof, without which a sex worker may face challenge availing public healthcare services. So all of these things that most of us have access to, they don't. Sex workers who have been trafficked and are living far from where they started their lives out, they are under the control of somebody else. They have absolutely no decision-making power. If they fall sick, very likely, the person who is controlling them is going to say, just take care of it. That's not my problem. Take care of it. I'm not going to pay good money to get you tested for this or to get you treated for this. Sort it out. And that's it. That's the end of that. Sex workers who get pregnant, they may not have access to safe terminations, right? And very often they have to figure out ways of getting it done themselves. And just in terms of decision-making power, okay, I'm not feeling very well today, I'd like to go see a doctor. Things that you and I might do without even thinking twice, that is not a luxury that they have. The nature of the work itself may compromise their ability to access care. There is, I don't know how many of you are familiar with this absolutely beautiful book called, it's called The Stranger Truth. And that's something that I'm going to recommend as a reading recommendation at the end of this, and will be part of the learning material that we send across. It's a book by Ashok Alexander, who led the Avahan program in India. It was funded by the Melinda and Bill Gates Foundation, but it was one of the largest HIV prevention programs that ran. And that book actually gives you deep insight into some of the huge problems that sex workers face. It also tells us that a lot of sex workers are migrant populations. There are corridors along the country that sex workers move seasonally in order to get work. There is a corridor from North Karnataka going up to Maharashtra. There's another corridor going from the coastal Andhra Pradesh into central India. And because they're on the move, they have the added layer of vulnerability that a migrant worker has, right? And so for them to access healthcare then becomes doubly difficult. And of course, a lack of good quality public clinics. How many good quality public clinics are available to this population? Not many, hardly, if at all. Of course, health workers are not sensitized to special needs of sex workers. There was, one of the stories that came out in the book, The Stranger Truth, was when, this this group called together a bunch of sex workers and said to them, okay, you need to start using more contraception, and you need to get your client to use contraception, to use a condom. And one of the women made a very interesting, her response was, no, I can't do it. And when she was asked, why won't you do it? I mean, you can get HIV and you'll die in a few years. She said, yeah, I know I'm going to die in a few years anyway, but I'd rather not die tonight. And when she was asked, what do you mean by you won't die tonight? She said, if I force my client to use this condom, he's going to beat me up and he's going to rape me anyway. And then I'm not going to be able to go back home and look after my child, and I might just die from the beatings. So I would rather take the HIV risk than be beaten up by a client. Now, to me, that was an extremely poignant insight, because that is not something that we think about. It's not in our worldview to even have to make a decision like that. And when we talk about, okay, dispensing contraception and all of that, and why won't these people engage in more healthy behaviors, we don't realize that some of the things that are influencing their decisions come from areas that we don't even think about, right? So we need to be sensitized to the various problems that they face and why they would prioritize or deprioritize their health in a particular setting. And there are, apart from all of those things, there are just basic structural barriers, like long waits, just waiting a long time to go and see a healthcare professional who's willing to see them. Restrictive hours. They may not be able to go at a time when the healthcare clinic is actually will automatically put people on guard. A fear of arrest. Today, their legal rights are not clear. They're not recognized as, this is not recognized as legal work. So if they're worried that if they go in to get, healthcare, a checkup done, or go in for some procedure, or go in for a treatment, they're going to be reported, and because of that, they'll be arrested. This requirement for a legal status. Now, this is something we covered recently, identification and all of that. Inconvenient location. A lot of where they might be located is not close to a public healthcare service, or maybe public healthcare services are not provided in those areas. The inability to pay, simple and straight up. A lot of sex workers are not in control of their finances. Their finances are controlled by people who control them in turn. And so they don't have the ability to pay for treatments that they might need. Lack of transport, such a basic thing, but they may not have it. Confidentiality. We all talk about the ethic of confidentiality, but it's very rarely practiced, especially if the person concerned is a sex worker. And if they're worried that their identity will be revealed or whatever, then they're not going to go to a person who they suspect will not treat their case with confidentiality. And of course, lack of access to social workers. We don't have enough of a workforce that is going out and engaging the sex work community. One of the most successful, one of the reasons why the Avahan program was so successful was because they were able to go into the communities, engage the sex workers themselves, activate them to become champions for healthcare. Eventually, it was not a top-down approach. It was going in and getting the community, people from within the community, to mobilize themselves, see the value in accessing healthcare, and then going out to their colleagues and to their associates, and then spreading the word. So that's how the Avahan program actually was quite successful. And finally, in terms of health-seeking behavior, how much education that is dispensed to the healthcare fraternity as well as to sex workers themselves has a direct relation to how they actually seek out health. It's like I talked about in that story. It's not just about telling the sex worker to use a condom, but the people who actually go and access the services of a health worker, of a sex worker, they need to be educated as well. Now, because of the nature of the work, we are never going to know who the clients are. Nobody comes out and says that they access the services of a sex worker. So how do you educate that lot of people who are so secretive about the fact that they visit sex workers in the first place? But then when we put the onus of control on the sex worker alone, it's not going to work, because there are two people involved there. Sex workers are hesitant to seek care for reproductive tract infections and sexually transmitted infections, obviously, because I think this is kind of stating the obvious, that the amount of shaming that will go into that is astounding. There is no compassion that is shown to a sex worker. If a sex worker gets a sexually transmitted disease, uh, I don't know how many healthcare professionals will actually sit down and try and understand what that person's story is, or how it happened, or why she did not access any sort of, did not take any measures to keep herself safe, and so on and so forth. And of course, the proportion of sex workers availing regular testing and counseling services is very variable across different parts of the country, but overall it is low. So this is a general trend. And what we do know from various different studies, there is no consolidated study on this. There are various things that have come up, and at the primary care level, there is a reporting of depression and procedures. So procedures meaning probably like termination of pregnancies and so on. But there is now a growing number of reported cases of depression among sex workers, and that is emerging as a trend as per some studies. And of course, sexual health, we just discussed it. There is a lot of stigma, there's a lot of lack of awareness, and so on and so forth. Cervical screening is very low. This is a trend now. People are becoming more aware of contraception and seeking contraception measures and so on. And that is largely due to programs like Avahan. And I know there are lots of other people. There was a very successful program running in Mysore for some time as well. And so because of that, there is more awareness about it, and people are seeking more contraception. The antenatal care is very variable. And as far as, law enforcement services, I think it's kind of obvious that reporting to police is very low. Now, why would someone seek police or forensic services? There's a lot of violence in the sex work community. They're subjected to tremendous amounts of violence. And but if somebody is treated violently, or is beaten up, or is assaulted, it's very, very unlikely that a sex worker will go and seek law enforcement assistance because of the nature of the work they do. And so because of that, they end up suffering much more than they would, and they don't have access to those rights that we have. So this is something that we need to be aware of. There is a sort of a trinity that exists in the sex work sphere, and that is, of course, high incidence of HIV and other sexually transmitted illnesses. Substance use tends to be high, and there is a very, very significant percentage of violence. And there is a correlation. The HIV it's twofold. It could be because of the actual sex work, or it could be because of substance use. Now, there is a strong correlation between substance use and HIV, and I think in our substance use session, we did touch upon it. There is so much trauma associated with being in this line of work that a lot of sex workers turn to substance abuse just to sort of escape it in their heads. And this becomes a downward spiral, and then there's a lot of sharing of needles and this and that also sort of compounds the problem of HIV. And it's not to say that all sex workers end up becoming substance users, but sometimes just to pay bills, just to it might also be the opposite, where a substance user to fuel a drug habit or to fund a drug habit may turn to sex work in order to make money to buy drugs. So there is also that equation that is happening, and violence, of course, is an offshoot. These are not protected people. Law enforcement, like I said, will not come to their rescue, and so they are subjected to quite a bit of violence at the hands of the people who control them, as well as their clients. And because in the absence of any systemized policies that protect sex workers, there is no safeguard against violence. So that's something that we need to be sensitive to. We don't have much more time, so I'm just going to wind this up with why palliative care. Some of you must be wondering, why are we talking about sex workers and migrant workers and tribal populations in palliative care? If we don't do it, who will do it? Today, there are no healthcare systems in place for these communities. And by definition, palliative care seeks to relieve and prevent suffering, right? And these are some of the communities in our country that are at very high risk for suffering. Richard Horton, who's the editor-in-chief of The Lancet, he made this really incredible statement. He said, obstacles to accessing palliative care affecting those living with serious health-related suffering are without any doubt the most disfiguring inequity in healthcare today. Palliative care does not just seek to alleviate physical suffering, our goal is to alleviate and relieve suffering in all spheres, because health is not the absence of disease, but it's also the presence of well-being, right? And what we seek to do through palliative care is also to address the inequity in the healthcare system today. There is deep, deep inequity in the way people are given healthcare, they offered it, or they, and while uh, without offending anybody, I mean, it's easier to talk about a cancer patient than it is to talk about a sex worker with a sexually transmitted disease. It is easier to talk about someone who is more in our worldview, someone who thinks like us, behaves like us, as opposed to talking about a person from a remote tribal community that has belief systems that are vastly different. And it's very easy to, live where we do, have a home a roof over our heads, have a place that we call home, work out of a space that we call the shots. But it's very difficult to see what a migrant worker goes through, right? But they're as human as we are, and they have health issues just as we do, and they would like to be around their families when they're not well, just like we would like to be. But then they're in such faraway cut-off places with such barriers of language and social etiquette and all of that, that they do get left behind. So these are the invisible patients in our society. And when we talk about invisible patients within a family unit, like we go to see a patient, we try and talk about who is the invisible patient in the family who might be suffering because of the illness. This is something that I would like to zoom the lens out and ask you to sort of identify invisible patients in our society. And to me, very clearly, these three groups definitely fall into that category. There are several other groups that we will be talking about as we go along, but this is where I'm going to stop today. So, Raju, over to you.
Thank you, ma'am. It was really an informative session. We could know about three marginalized groups: the tribals, the sex workers, and the migrant population. I really agree with when you said that they are hardly part of our national policy. Like we hardly know about them, but we are very strong that we know what policy should be needed for them. So I think we can have quick question round. You can either raise your hands or unmute yourself and speak. Pranav sir?
Yeah, am I audible?
Yes, sir, you are.
Ma'am, your teaching, your session is very good. But one thing I want to clarify, what are the factors responsible for marginalization?
Are you talking about one of the groups in particular, or?
No, in general.
Oh, that's a very vast question. What are the factors?
No.
There are social factors, there are political factors, very strongly political factors, I would say. And there are historical factors. So I wouldn't really be able to tell you in a nutshell in even 3 minutes what those factors are. I mean, there are several factors, and if you take each of these marginalized communities, the combination of factors might change. So I don't want to paint it with a just a broad stroke. The factors that contribute to substance abuse, the factors that contribute to sex workers, the factors that contribute to migrant workers, medically marginalized people, they all have different variables that come together that keeps them marginalized. But I would say that the common factor would be political in many ways. Societal and political. It always serves somebody's purpose to have a disempowered group. So I don't want to say anything that's going to get me into trouble, but there are very strong factors always.
Yeah. Not that, ma'am. One more, just curiosity. India is a land of diversity, economic, social, cultural, political, religion. Why the word marginalized is coined?
Because what you have just described, a country of diversity, is an idyllic. It's an idyllic description. Yes, we are diverse, but diversity does not mean equitable.
No.
Diversity does not mean equality. So there are always marginalized groups. So there's a different. So it's great to have a diversity in our population, but by its very existence, diversity does breed inequity.
That means they are leaving margins of the mainstream.
Yeah, in
That's
some way
why
or the other.
yeah.
Yes.
Yeah. Okay. Thank you.
Thank you, sir. Any more? Is there anyone who have been working with any of these groups as part of your social work career?
Yes, I would really like to hear from people who have direct experience. Rebecca.
I've been in the targeted intervention for almost 12 to 14 years now. So sex workers happen to be the smartest and the sweetest people on earth. Especially
Would you like to share any incident that really moved you or something that taught you a lot? That would be great if.
that is totally unrelated to our topic right now. But I happened to see a sex worker who fell in love. And I could see how intense her emotional state was. And then I was kind of trying to understand where they do the line between physical and emotional sex. And it was just their bodies that had the sex part. Emotionally, they are absolutely intact as every other person. And in fact, their emotions are all the more intense because it comes from a state of purity. So that was my most moving experience with these women.
Thank you. I mean, that is such a incredible statement to make, because people tend to think that physical sex and an emotional the emotional component are tied up. But like you said, in a lot, it becomes a matter of I think self-care for them to make that distinction, and then it becomes more intense when it's actually an emotion that they feel.
And another thing that I wanted to add in terms of control among who controls their, the control is more in the brothel kind of a setting. It's kind of lesser in a street-based setting, or nowadays it's changed. But earlier, say some 10 to 12 years back, it was more of a brothel-based setting here in Tamil Nadu especially. But recently it's been like a deconstruction, and women are more empowered and independent these days. So it's not actually bad, their health status, since I'm working with TI, but there are still lots more of unreached populations that we need to reach more. As you said, the marginalized community are getting the brunt of it. But things are better right now, but of course it has to be, uh, there needs to be more intense work in that area. And even when it comes to palliative care, I think if palliative care could also be a wing of NACO, then it would mean holistic uh, health care provision.
So that's something that we could definitely explore, I think, Rebecca, because now we're talking about incorporating palliative care into disaster management and things like that. So absolutely, why not? Why
Because they
shouldn't
had
palliative?
something like a community care center earlier. I'm not too sure. This happened, I think, a decade ago. But if those community care centers do come back into existence, and palliative care is one wing of that, I think it would make a lot of difference for sex workers, MSM, TG population, everybody. And the migrants are also covered through the TIs, targeted intervention.
So may I take your permission to direct people to you if they have, certain questions specifically about integrating palliative care in working with these communities? Because
Uh,
it's good
I
to have a
I can sort
discussion
of
about.
help. I don't know how smart I am regarding this, but in giving direction per se or help or guidance, but I can put them on to people who might be smarter than
I wouldn't play down your smartest that much. I've
just to
Okay.
give them correct information.
Thank you, Rebecca.
Thank you. Thank you.
Sure, Rebecca, ma'am. Any more? Any more comments or doubts? Anything you want to make more clear on? I suppose there isn't anything, ma'am.
Thank you. And yeah, if any questions come up later, I'm happy to take them offline also.
Yeah, either you can write to us or call us. We will answer all your queries. So thank you all for joining in. So we can see you on next Friday with the continuation of marginalized community itself taken by Smriti ma'am.